Hi everyone, welcome. This is Desi Vijay. I'm the North-South National Team Member and a coordinator for webinars. Glad to see you all here and hope you're all enjoying the nice spring weather. Now we are continuing with our regular webinar series on general topics of interest and importance. We are really pleased to have the representatives of American Lung Cancer Screening Initiative here with us and to educate us about this deadly disease. And the presentation today is literally a life and death issue, and I thank you all for attending and learning about this deadly disease. I'm really glad that we were able to bring this to our webinars today, and welcome for yet another exciting webinar. Before we proceed, as usual, let me get through the regular housekeeping comments. We have a few poll questions today, and we'll be posting them, some of them in the beginning and some of them after the presentation. Please pick your answer as quickly as possible. Once we move on to the next one, the previous ones have to be closed. We will have about less than a minute to answer all the questions, so please help us out. Thank you. This webinar is getting recorded, and we will send you the link to all of you within a day or two. If you want to listen to any of our previous webinars and you do not have the link, please let us know at webinars@northsouth.org. And also, there are some past webinars available in our North-South YouTube channel. Please subscribe and then you can watch. If you have any questions you want to ask the presenters, please type them out in the questions tab. We will collect them, ask the panel on your behalf after the presentation is completed. Please be patient and please do not keep repeating the same questions. It really makes it harder for us. We also will try to answer all your questions before we conclude, but however, we have a time limit of an hour and a half maximum for this session. So if we are not able to get through to all the questions, we will definitely have the presenters answer them privately and then we will communicate back to you. Thank you for your understanding, cooperation. Before we leave, please take a moment to fill in the feedback questions. This has helped us in the past and it will definitely help the presenters to know how they did today. Please help us out here. And finally, thank you for, I'll take this opportunity to thank you all for the successful webinars. We have been doing it without your help and support. We couldn't have done it. Let's move on to the scheduled webinar topic. 35% of them think it's 10 to 20%, and 29% of them think that it's 3 to 5%. So Priyanka or Alex, you can give us the right answer.
I can go ahead. So the answer, this question is based in the United States. So in the US, about 10 to 20% of individuals diagnosed with lung cancer have never smoked before. It is higher in Eastern Asian countries, where, especially for women, where it's about 70 to 80% of women diagnosed with lung cancer in Asian countries are never smokers. So the point is although smoking is the primary risk factor for lung cancer, there are a large number of individuals who have never smoked who do get lung cancer.
Wow, that's really high than I thought.
Yeah.
Let's move on with the topic, and I'm really interested to hear from them. We have with us President of North-South Foundation, Dr. Balu Natarajan, MD. He would be here introducing the panel to us. As all you know, Dr. Balu Natarajan is also a medical doctor specializing in internal medicine and sports medicine and hospice and palliative medicine. And I'm really appreciate he being here to participate in this webinar. I welcome Dr. Balu to introduce the panel to all of you. Here is Dr. Balu.
All right, I'm really excited that Ms. Senthil and Ms. Potter are here with us. Hopefully Dr. Yang will be able to join us as well. Priyanka is a senior. You've seen her before if you've joined these webinars in the past. She's a senior in high school in Reno, Nevada. She loves neuroscience and participating in brain bee competitions. In 2019, she was our very own North-South Foundation Brain Bee National third place winner. And outside of school, in her copious free time, when she's not studying the brain, she's using it, working in research labs at the University of Nevada, Reno, and cross-country at Massachusetts General Hospital virtually. Some of her projects have been studying the role of inhibitory parvalbumin neurons in neuroplasticity and studying synaptic transmission in the mouse brain using the calyx of Held as a model synapse. She is a member of the team in Chi-Fu Jeffrey Yang's lung cancer research lab and is also a part of the outreach team of the American Lung Cancer Screening Initiative. And I do want to just take a moment and appreciate Priyanka for not just her work, but for proactively reaching out and making sure that this webinar happened. That is, at a very young age, that sort of initiative is really what affects change, and we're really excited and proud of that. Alexandra, welcome. Alexandra is an undergraduate at UC Berkeley, where she studies bioengineering, and she also works in Dr. Yang's lung cancer research lab. She's very passionate about lung cancer research and raising awareness about the importance of lung cancer screening. She is the program director for the American Lung Cancer Screening Initiative, and in fact, in 2020, she co-drafted the first House and Senate resolutions to support lung cancer screening, and has worked with communities across the world to raise awareness for screening. Current focuses include working on lung cancer research in Dr. Chi-Fu Jeffrey Yang's research lab and working to help more high-risk individuals get screened for lung cancer. Hopefully, Dr. Yang will join us. He's a thoracic surgeon at Harvard's Mass General Hospital and an assistant professor at Harvard Medical School. His research focuses primarily on lung cancer research and thoracic surgery outcomes research. He's written almost 100 articles, has co-first authored or first authored over 50 publications. In addition, he is the founder of the American Lung Cancer Screening Initiative and worked with communities across the world to raise awareness for lung cancer screening. And before I turn it over to these two wonderful young women, I do want to say that these are screening guidelines that are not just theory. I use them in my practice, so it's very relevant. It's something that's literally brought to life every single day, and an incredibly important goal. We've seen the effects of things like colon cancer screening in saving lives and allowing our loved ones to be with us for many years longer. And hopefully we will see with the augmented lung cancer screening a very similar outcome as well. I'll turn it over to both of you. Welcome.
Thank you so much, Dr. Balu, for the kind introduction, and thanks to NSF for giving us this great opportunity to present today. So without further ado, let's get right into the presentation. Today we'll be talking about lung cancer and lung cancer screening. So before we get started, I'd like to request that everyone is muted during the presentation. However, we would love to take any questions at the end of the presentation. So please feel free to put your questions in the chat box for either Alex or I to address. And if you are interested in learning more about the American Lung Cancer Screening Initiative, we'd like to invite you to visit our website, www.alc.org, and please email us with any questions at any time. So before we get into the content of the presentation, I'd like to share a little bit about what the American Lung Cancer Screening Initiative does. So we like to call the American Lung Cancer Screening Initiative ALC, and it is a 501c3 nonprofit that works to raise awareness for lung cancer and lung cancer screening. And we're a team of over 50 passionate students and doctors located across the United States. We worked with various community organizations like the South Asian Network and the American Indian Cancer Foundation, as well as city and state health departments, including the NYC and Connecticut health departments. And we hope that by educating communities about lung cancer and lung cancer screening, high-risk community members will be encouraged to seek lung cancer screening. So today we will discuss both lung cancer and lung cancer screening, addressing questions such as how common is lung cancer, what is lung cancer screening, and how you can get screened. So to start things off, lung cancer is very common. It is the second most common cancer in the US, excluding skin cancer. It is also the most fatal. So this graph shows the American Cancer Society estimates for the number of new cancer cases in the United States. And this graph estimates new cancer cases in 2020 for the 4 most common cancers. And as you can see, it was estimated that 228,820 people were diagnosed with lung cancer in 2020 in the US alone. So just to put this number in perspective, it is estimated that about 6% of people will develop lung cancer during their lifetime in the United States. So this means that about 1 in every 15 men and 1 in every 17 women will be diagnosed with lung cancer. Moreover, not only is lung cancer very common, but as I mentioned before, it is also very fatal. Lung cancer is the leading cause of cancer-related death in the US and the world. In 2020, it was estimated that lung cancer claimed the lives of 135,720 people. And this graph shows the American Cancer Society estimates for the number of cancer-related deaths in the United States. So as you can see, lung cancer is far more fatal than breast, prostate, and colon cancer. In fact, causing more deaths than all 3 of those combined. And every year, there are about 50,000 more new cases of breast cancer, but lung cancer still causes over 90,000 more deaths. In fact, in women alone, every year, lung cancer causes more deaths than breast, ovarian, and uterine cancer combined. So if we look at lung cancer incidence and mortality by sex and race, you can see that among males, lung cancer incidence is highest in Black males at an incidence rate of about 71.7 per 100,000 people. And among females, lung cancer incidence is highest in white females at an incidence rate of 44.7. And as you can imagine, mortality rates do mirror incidence rates. So Black males have the highest mortality rate amongst males, and white females have the highest mortality rate among females. So from this data, the question that arises is, why is lung cancer mortality so high? Well, lung cancer mortality is so high because patients are typically diagnosed at a later stage. So this graph is looking at the proportion of patients with lung cancer by stage. And stage is just a way for doctors to classify a cancerous tumor based on several different factors like tumor size, whether the cancer has spread to lymph nodes, and whether the cancer has spread to other locations in the patient's body. So currently, most lung cancers are diagnosed at a distant stage, when the cancer has spread beyond the site in which the lung, where it originated. So this graph is based off of data from 2008 to 2017, published by the National Cancer Institute. And as you can see, about 21% of patients are diagnosed at a localized stage, while about 51% of lung cancers are diagnosed at a distant stage, when the cancer is already spread to other locations in the body. So why is this important? Well, it's important because the stage that lung cancer is diagnosed at directly correlates with survival. And we'll see this in the next slide. So one way that doctors track survival of patients is by looking at 5-year survival. And as you can see here, as imagined, the 5-year survival for a lung cancer at the early stage is high, but the 5-year survival significantly drops as the disease progresses. This graph is another way to understand the relationship between stage and diagnosis at 5-year survival. The 5-year survival for patients with localized lung cancer is 59%, but only 23% of lung cancers are diagnosed at this stage. In comparison, nearly half of lung cancers are diagnosed at the distant stage. So this is why early detection of lung cancer is so important. Because if we can detect lung cancer at an early stage, then treatment options are going to be better and prognosis will also be better. With lung cancer being such a morbid disease, some of you might be wondering why the majority of lung cancers are diagnosed at a later stage. The reason for this is that the majority of patients are diagnosed at a late stage since they don't start feeling any of the symptoms of lung cancer until the cancer is already grown and spread. The most common symptoms of lung cancer are chronic cough, coughing up blood, chest pain, and shortness of breath. And some additional symptoms may include hoarseness, loss of appetite, fatigue, and lower respiratory infections. So, however, whenever a person does become asymptomatic, the cancer has usually already grown and spread to a point where it is more difficult to treat and the prognosis is poor. So if the diagnosis of lung cancer has to wait until a patient has symptoms, it is difficult to catch the lung cancer early. So the question we ask is, how do we catch lung cancer early if patients are asymptomatic? And one of the best ways to do this is through lung cancer screening. Lung cancer screening is done using something called the low-dose computed tomography scan. If you are eligible for lung cancer screening, it is recommended that you get annual lung cancer screening. And in the coming slides, we will discuss what lung cancer screening is, who should get screened, and how to get screened. An important distinction that we want to make is that lung cancer screening is done using low-dose computed tomography, also known as low-dose CT, and not the chest X-ray. We use low-dose CT scan because it provides more detailed pictures than chest X-ray and is better at finding small abnormal areas in the lungs. The picture on the left is a picture of a chest X-ray, and the yellow arrows point to the abnormal area in the lungs. But as you can see, it is a bit unclear. On the other hand, the image on the right is a picture of a low-dose CT scan of the chest, and the red arrows here point to the abnormal area in the lungs. And as you can see, this image is a little bit more detailed than the chest X-ray and enables you to see the abnormal area with greater detail. So the question that researchers wanted to ask is, how effective is the low-dose CT scan at detecting lung cancer at an early stage? And an important lung cancer screening trial is called the National Lung Screening Trial, or the NLST, and they try to answer this very question. So the NLST was a large national study with over 50,000 patients. And the goal of this study was to determine the effectiveness of using low-dose CT scan to detect lung cancer in patients considered high risk for lung cancer. And this study included two groups. So one, a group of patients who received annual low-dose CT scans, and a group of patients who received annual chest X-ray. And so by comparing the stages at which cancers were caught between these two groups, the study wanted to determine if the low-dose CT scan was better at catching more lung cancers at an early stage. As you can see, of everyone diagnosed with lung cancer, the low-dose CT scan caught the most lung cancers at an early stage, while the X-ray diagnosed more patients at stage 4. And this has important implications for survival. Because low-dose CT scan caught more lung cancers at an early stage, these cancers were more likely to be treatable and the prognosis was likely much better. And so this translates to about a 20% reduction in mortality for those who underwent lung cancer screening using low-dose CT compared to a chest X-ray. However, a concern with any screening test is accuracy. So essentially, how good is low-dose CT at catching lung cancer? For every 100 individuals undergoing CT lung screening, about 75 will be negative. And of those 75 that are negative, 97.7% to 100% truly do not have lung cancer. So this means that the test is very good at identifying people who do not have lung cancer. So that is, if you have lung cancer, the test will most likely come back positive and the test will not miss your cancer. So if we move our attention to the 25 individuals who are positive, 23 will turn out to be negative for cancer, primarily with follow-up imaging alone. So this means that even if your test result is a false positive, it's really easy to rule out cancer using further non-invasive imaging. And the two individuals that have a positive test result and truly do have lung cancer are more likely to be diagnosed at an early stage than if they were not to undergo lung cancer screening. So this again means that their treatment options are going to be better and their prognosis is going to be better. The results of the Nlst study were published in 2011, so about 10 years ago, and several studies have been published since then, further confirming the life-saving benefits of lung cancer screening in high-risk populations. And one of these important studies is the Nlst trial. In February of 2020, the results of the Nlst trial were published, and like the Nlst, the Nlst trial had two groups. However, unlike the Nlst had a group that received low-dose CT and a group that received no screening of any kind. A total of about 13,195 men and 2,594 women between the ages of 50 and 74 were randomly assigned to undergo CT screening at T0, which is baseline, year 1, year 3, and year 5.5. Or they did not undergo screening at all. So the results confirmed the life-saving benefit of lung cancer screening by low-dose CT. In the screening group, 58.6% of lung cancers were diagnosed at stage 1. In the non-screening group, 13.5% of lung cancers were diagnosed at stage 1. So a far lower percentage. Therefore, this study shows that early detection translates to a reduction in mortality. At 10 years to follow-up in low-dose CT group, there was a 24% reduction in lung cancer mortality in men and a 33% reduction in lung cancer mortality in women. And this is compared to no screening. So the Nlst trial also showed that with improvements in low-dose CT technology, the false positive rate can be significantly reduced. So just to summarize, lung cancer screening significantly reduces lung cancer mortality. But you may be wondering who should get screened for lung cancer. The United States Preventative Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. Right now, they recommend that people between the ages of 50 and 80 who have a 20-pack-year smoking history or greater and who are current or former smokers who quit within the past 15 years get annual low-dose CT scans. The current screening guidelines require you to have a 20-pack-year smoking history, but pack-year history might not be a term that some of you have heard before. But it is just a way for doctors to basically track your smoking history over a period of time. A pack year is defined as smoking a pack of cigarettes per day for a year. So for example, if you were to smoke 1 pack a day for 20 years, that would equate to a 20-pack year smoking history. Alternatively, if you were to smoke 2 packs a day for 10 years, that would also equate to a 20-pack year smoking history. So the important takeaway is that there are many different ways to reach a 20-pack year smoking history. And the pack year is just a way to help doctors track your smoking history. So I'd also like to point out that the USPSTF guidelines were recently updated. So the USPSTF had slightly different guidelines a little over a month ago, and they updated their screening guidelines on March 9th, 2021. So the previous guidelines only recommended that individuals between the age of 55 and 80 with a 30-pack year smoking history or more get screened. Under the new guidelines, the lower age bound is lowered from 55 to 50 years, and the pack year smoking history is lowered from 30-pack years to 20-pack years, which is a huge change. So these new guidelines will nearly double the number of eligible individuals for lung cancer screening in the United States. And notably, the most apparent increases in eligibility will occur among women and minorities. However, while these new guidelines will include more high-risk individuals, they only include individuals with heavy smoking histories. There are other risk factors, though, for lung cancer that are not accounted for in the current screening guidelines. These additional risk factors include things like exposure to secondhand smoke, exposure to radon, exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. It is important that we recognize these additional risk factors because while lung cancer has a strong association with smoking, there are a large number of people in the United States who have never smoked that still get lung cancer. So never smokers are defined as individuals who have smoked less than 100 cigarettes in their lifetime. Because lung cancer has such a strong association with smoking, people are often surprised to learn that lung cancer in never smokers accounts for about 10 to 20% of lung cancer diagnoses and is the 7th leading cause of cancer-related death in the US and the world. More never smokers die from lung cancer each year than people die from ovarian cancer, which is an astonishing number. So this graph shows a proportion of lung cancer cases that occur in people who have smoked in their life and people who have never smoked. It is also further broken down by whether they're current, former, or never smokers. So as you can see, 80 to 90% of lung cancers occur in people who have smoked in their lifetime, but about 10 to 20% occur in never smokers. Interestingly, women are more likely to be never smokers when diagnosed with lung cancer. And in fact, in the US, 60 to 70% of never smokers diagnosed with lung cancer are women. So right now, the lung cancer screening is not recommended for individuals who have never smoked. However, understanding lung cancer in never smokers is a current focus of study. So with the development of new screening technologies and risk models, there may be a way to identify high-risk never smokers who should also be screened for lung cancer. So in summary, lung cancer is the leading cause of cancer-related death in the US. And it is so deadly because most lung cancers are diagnosed at a late stage when it has already spread to other locations in the body. Importantly, early detection through lung cancer screening by the use of low-dose CT can reduce lung cancer mortality by up to 33%. However, currently only 5.7% of high-risk individuals are currently getting screened for lung cancer. And just to highlight how low this number is, we compare the lung cancer screening rate to the screening rates for breast, cervical, and colon cancer. All 4 of these cancers have screening tests that are recommended by the USPSTF. But right now, only 5.7% of high-risk individuals are getting screened for lung cancer. This rate is extremely low in comparison to the screening rates for breast, cervical, and colon cancer. In fact, the American Lung Association estimates that if we were to screen every high-risk individual recommended by the USPSTF in the US, we would save 48,000 lives. However, again, only 5.7% of people are getting screened, which means that a lot of lives that could be saved are not being saved. So why is that? The lung cancer screening rate is low for a number of reasons, including limited awareness and concerns about things like access to screening, the cost of screening, and the safety of screening. So in the next few slides, we'll discuss each of these topics. The important takeaway, though, again, is that lung cancer screening can help reduce an individual's risk of dying from lung cancer. So the first potential concern that we will address is the cost of lung cancer screening. The average low-dose CT scan costs anywhere from $300 to $400, but most insurance companies, including Medicare and Medicaid, will cover the cost for eligible patients. However, there are a few exceptions. So 1, Medicare will only cover lung cancer screening until the age of 77. 2, not all state Medicaid plans cover lung cancer screening. And 3, patients will still pay the usual fees for provider appointments before or after the scan. So as I just mentioned, unfortunately, not all state Medicaid plans cover lung cancer screening. Here's a map updated in July showing which state Medicaid plans do and do not cover lung cancer screening. Blue states have state Medicaid plans that cover lung cancer screening, while purple states do not cover lung cancer screening. And for the pink states, this particular information is not available. The first step to getting a patient screened for lung cancer is having them talk to their primary care provider, or PCP. So there are going to be certain questions a PCP has to ask and topics that need to be discussed. And one of these is the patient's past-year smoking history, which we saw how to calculate in earlier slides. And to find accredited lung cancer screening centers, patients can go to the American College of Radiology website, and they can type in the state or city they live in to see where accredited lung cancer screening facilities are located near them. The American College of Radiology website is listed on the bottom left-hand side of the screen. Since many NSF families are located in the East Coast near Massachusetts, which houses several accredited lung cancer screening facilities, we've chosen to show examples of screening facilities there. And as you can see, each red pin represents an accredited screening center. As far as how the experience of getting a low-dose CT scan goes, it will require you to lay on your back for about 5 minutes, and you will be doing something very similar to what the patient in the photo here is doing. And one thing to note is that this process will not hurt at all because this is a low-dose CT scan and you do not use contrast. So this means that there will not be any needles or injections involved. So the low-dose CT scan is non-invasive, fast, and completely pain-free. Additionally, the amount of radiation exposure is very low. So a way doctors measure the amount of radiation a patient may receive is through a unit called the millisievert. It is basically just a way to measure radiation and compares the levels of radiation received during different activities and over time. So for a low-dose CT scan, you will be exposed to 1.5 to 2 millisieverts of radiation. And this is a lot lower than a full chest CT scan, which requires a radiation dose of 8 millisieverts. So to put that in perspective, you are exposed to 3.11 millisieverts of radiation a year just from breathing, cosmic radiation, eating, and the radiation from the earth. So a low-dose CT scan exposes you to less radiation than you're exposed to from just existing on Earth, which means that the level of radiation that you receive from an annual lung cancer screening test is very small. That being said, this is always something that patients can discuss with their primary care provider if they're concerned. So a patient has talked with their primary care doctor and their PCP has referred the patient to a screening center and they received a low-dose CT. So what's next? Well, the doctor will receive the results of the patient's screening test and will follow up with the patient to go over the results. And as far as results go, there are 3 most likely outcomes. The first outcome is that the scans are normal. And if that is the case, then the patient should look to get repeat scans in about a year. If the scans are abnormal, but probably benign, then the patient should talk to their doctor about the next steps. And this may include more scans, tests, or biopsies. And if the scans are abnormal and suspicious, then the patient will most likely have to undergo additional testing, such as a biopsy. So, like we've talked about, lung cancer screening saves lives. But a question you may be wondering is, can individuals still get screened for lung cancer during the COVID-19 pandemic? And is it safe to do so? During the pandemic, the number of lung cancer screening centers has decreased significantly. However, lung cancer won't stop because of the pandemic. So if a patient is at high risk for developing lung cancer, it is important that they get their annual lung cancer screening test. So right now, most hospitals have operating lung cancer screening programs, and patients can wear a mask during the entire lung cancer screening process. So as long as patients follow the necessary precautions like wearing a mask, lung cancer screening during the pandemic is safe. And the pandemic should not deter patients from getting screened for lung cancer. And another question that we get often is how vaping and e-cigarette use affects lung cancer risk. Vaping and e-cigarettes are relatively new phenomena and have been more prevalent in the last decade. So while the long-term effects of vaping and e-cigarettes are still being studied, it is clear that for individuals who have never smoked before, they can increase their risk of lung cancer. So e-cigarette devices and vaping fluids contain nicotine derivatives and heavy metals, among other chemicals. These arise both as elements of the e-liquid and as a result of organic reactions in the electronic cigarette device. And various studies have demonstrated in vitro transforming and cytotoxic activity of these derivatives. So while vaping may cause fewer health risks than smoking, it is still not a risk-free activity. Vaping can increase things like heart rate, decrease air volume in the lungs, and increase airway resistance. Furthermore, e-cigarette device use has been significantly increasing, particularly among young adults and non-smokers, making it an area of significant concern for the future. Additionally, while lung cancer screening has the potential to save many lives, it is important to also address smoking cessation in the context of lung cancer screening. Lung cancer screening is not a substitute for smoking cessation, and likewise, smoking cessation is not a substitute for lung cancer screening. Smoking cessation is one of the best ways to prevent lung cancer, and lung cancer screening is one of the best ways to detect lung cancer. So using both of these methods is going to be the best way to fight the disease. In fact, for every year after an individual quits smoking, their risk for lung cancer is reduced by 8 to 17%, depending on the type of lung cancer they have. And another reason that smoking cessation is important is because it is required by Medicare and Medicaid services for lung cancer screening programs. However, we do understand that smoking cessation can be difficult. There are a lot of resources for people trying to quit smoking. And one great program is the American Lung Association's Freedom from Smoking program. So as this presentation comes to a conclusion, we want to end on what we, the American Lung Cancer Screening Initiative, are doing to begin the widespread awareness, education, and advocacy efforts necessary to increase the lung cancer screening rate. So as we've talked about, lung cancer is the deadliest cancer in the world. And while lung cancer screening can save so many lives, very few high-risk individuals are currently getting screened. We are working to address all aspects of this issue. We wrote and advocated for US House and Senate resolutions expressing support for Lung Cancer Awareness Month and early detection through lung cancer screening. Last December, our Senate resolution was passed by unanimous consent. Additionally, we are working to teach communities across the country about lung cancer and lung cancer screening. We believe that by working together, we can overcome lung cancer and save millions of lives. And really, it starts by raising awareness in our community about lung cancer screening programs. We believe that educating communities, especially students, about lung cancer and lung cancer screening is crucial to lowering the number of deaths associated with the disease. Students greatly impact and influence the healthcare of their parents. And we hope that by educating students about important measures that can be taken, we will not only be able to help the students, but also their family members. So we're so grateful to NSF for helping us set up this presentation, and thank you all so much for your time. We hope that you were able to leave this presentation with a better understanding of lung cancer and the lung cancer screening process. So as we know, lung cancer is a big problem. It is very common and very fatal. That being said, there are tools that we can use and actions we can take to help reduce lung cancer mortality. And one of the best ones and the topic of this presentation is lung cancer screening. The American Lung Cancer Screening Initiative is always looking to help raise awareness for lung cancer and lung cancer screening. So if you have any questions, please feel free to ask in this following Q&A session. Additionally, if you're interested in helping raise awareness for lung cancer screening in your community, we would love to work with you. So you can send us an email to info@alc.org. Okay, so now I would like to open the floor up to any questions that you guys may have. We welcome any and all questions.
Yeah, I'm just joined us. So do you have anything to say before we go to questions?
Just that we're very thankful for the opportunity to talk with everybody today about lung cancer screening.
There's a question, of course, I see Alex has already answered, but let me put it for the whole. I'm a 70-year-old and I don't have any symptoms of lung cancer. So still I have to do the screening? So,
Yeah, so can you hear me all right?
Yeah, please go ahead.
So the answer to that is it depends on your smoking history criteria. So you need to have a 20-pack year smoking history, and you need to either be a current or former smoker who's quit within the past 15 years. And actually, the USPSTF guidelines require that you are asymptomatic for lung cancer to get this preventive screening. So just because you don't have symptoms, if you do meet the criteria, it is currently recommended that you get screened for lung cancer.
Thank you. Dr. Bali, you can go ahead with questions.
All right, very good. I suspect Dr. Yang will have to answer this one. Is there a higher risk of cancer for people with asthma, especially with incidence of upper respiratory infections? And while you're at it, if you want to include COPD, that would be fine as well.
Yeah, that's a great question. There is a higher risk. However, right now with the guidelines, they don't really, with the USPSTF guidelines, they don't factor that in right now in terms of, it's really based just on smoking history. And smoking is still going to be the biggest risk factor for lung cancer. But that's something that, hopefully over the next few years, people will continue to work on figuring out how to put that better into the risk models, and the guidelines will continue to evolve as well. Alex, do you want to add to that as well?
Sure. I think you covered it mostly, but the thing to just be very clear about is that there are secondary risk factors for lung cancer, and factors that put you at a higher risk for lung cancer that are not smoking. So asthma and COPD and a family history of lung cancer, amongst other things, do put you at a higher risk for lung cancer, but we currently don't consider those risk factors in the guidelines for screening. But as Dr. Yang mentioned, that is a current focus of research, because as we saw in the first poll before the presentation, 10 to 20% of individuals in the US diagnosed with lung cancer have never smoked. So on that factor alone, just because they haven't smoked means they can't get screened for lung cancer right now. So it is a very important issue, and hopefully one that we will see continue to see addressed in the coming years.
Thank you both. Next question is here. Do we have a graph showing the percentage of lung cancer detected as a function of age?
Yes, so the American Cancer Society does have like a bar graph by age group of lung cancer incidence, and I think you can Google search it and find it. But to summarize, the median age of diagnosis for lung cancer is like 70 or 71. So it does typically affect older adults.
I can't remember. I don't know if it was in your slide deck. I think you did have a stage versus detection, right? Part of this is being able to capture it at an earlier stage. Was that among the slides? If so, it'd be good to put it back up.
Yeah, I think so. Let me see if I can pull that.
Right, because that's really one of the biggest reasons we do screening, right? Is if we can catch it early, we can do something about it. And so if you can pull that up and just walk through that one more time, because I think it reinforces why the discipline of screening is worth it.
Sure. Is this the slide that you were talking about, Dr. Ball?
Yeah, so this is survival, right? But I don't know if you had anything associated with lead time, right?
There was
meaning,
yeah, that's the one. Yeah, horizontal bar chart.
Okay, yeah, so exactly. So basically what this graph is showing is that only 23% of patients are currently diagnosed. Their lung cancer is only being diagnosed at an early stage. So it's a very small percentage of patients who do have lung cancer. And when they are diagnosed at an early stage, they have a much better 5-year survival, which is about 59%. However, as you can see, the majority of patients are being diagnosed at a distant stage. So about 47%, so close to the majority of patients. And their 5-year survival is about 6%, which is way lower than if they were diagnosed in early stage. And that's why lung cancer screening is so important, because that is one of the primary ways that we can detect lung cancer early. And again, the reason why lung cancer right now is often being detected at such a distant stage is because patients are asymptomatic. And when they do feel the symptoms and when they do go to the doctor and talk to their PCP about getting screened, it's often too late, and their prognosis is not going to be as good as it would be if they were diagnosed early.
So if we take this to its natural end, right, if we actually get more and more screening, right, and we can get it at the right time, we will get more lung cancer diagnoses, right, but they will be earlier. And so the average age of diagnosis might change from the 70s to the 60s, but by catching them early, we'll be able to do something with it. So the answer to the question may change, right, if our screening gets better and if people across the United States and across the world start adopting what we learn from that research. Next question is, I want to go to the incidentaloma question here as soon as I can find it. All right, if a CAT scan finds an incidental lung nodule, is biopsy a better option rather than actually removing the nodule? If so, why? And Dr. Yang, I think you have a more complete answer than either of those options.
Well, so I think that's a great question. Right now, in addition to lung cancer screening, a way that we often find these nodules early is what we call through just these incidental findings. So for example, if somebody had a cough and had pneumonia, they went to the emergency room and they got evaluated for shortness of breath, they'll often get a CT scan, and sometimes that will show a lung nodule. And usually what will happen, obviously each case is different, but if this is the first time we've seen this as a lung nodule, then, and depending on how it looks, but if it's still relatively small and it doesn't look like a lung cancer, we're not sure what it is exactly, we'll get a short-term repeat CT scan, or we can, as the question is alluding to, we could also just get a biopsy of it, which is usually we have our radiology colleagues use a needle and just put it right where the nodule is and remove some of the tissue and figure out if it's cancer or not. The other thing you could do is just perform a operation, usually minimally invasively, where you just take out a small piece of lung tissue. We call that a VATS wedge resection, where we use a camera and thin instruments and then take out some of that tissue. I think that it's the way to really fully answer your question. I think it just depends case by case on how large that nodule is, what that nodule looks like. Sometimes what happens is that the needle biopsy doesn't get enough tissue and we don't know what it is. And then the next best step is to get an operation to remove that tissue. And so some people feel that if they're worried enough that it's cancer, then they'll go ahead and just skip that biopsy step and then just go straight to being in the operating room and taking out that small lung tissue, small piece of lung tissue. And if that comes back as cancer, then just during the same setting, perform the operation to officially remove that cancer. So.
Great. And the one thing I will add, right, is if somebody tells anyone who's watching, right, that you have an incidental nodule, the biggest thing to make sure you know is, when am I supposed to get my follow-up, right? Because a lot of times they'll just say, you need a repeat CT. And so just make sure you know when you're supposed to get that repeat CT. And there are many, many times where they'll get one more or two more, and then that's it. You don't need anything more after that. So, you know, the question here is asking about biopsy versus surgery, but many times you don't need either one of those things, but you do need to take responsibility for the follow-up. So.
Yeah, exactly. I've definitely had situations where the nodule was there and then it just disappeared. You know, so sometimes too, if we're worried, if they have a smoking history and things like that, you get the CT scan, and then you go ahead and get a PET scan, which is like a CT scan, but it's where you give the patient some sugar that's labeled with radio tracer, and it helps you figure out what might be cancer or not. And then sometimes even during that interval, the nodule just goes away. So it depends. And then obviously the other spectrum happens too, where it comes back as cancer on the biopsy. So.
All right, thank you. I'm going to combine 2 or 3 questions here. The questions are, what are the leading causes of lung cancer for non-smokers? What are causes for lung cancer other than smoking or secondhand smoke? And is inhalation associated with wildfires a cause for lung cancer? So basically a multi-question around non-smoking causes of lung cancer.
Yeah, Priyanka, do you want to go ahead and take a stab at this?
Yeah, sure. So we had a slide in this presentation that talked about some of the other additional risk factors for lung cancer, and it's right here. So this is symptoms of lung cancer, but some of the additional risk factors for lung cancer do include like a family history of lung cancer, exposure to asbestos, exposure to radon, things like that. Definitely, I'm not so sure about this, but I do think inhalation of smoke and studies have shown that exposure to smoke during infancy and childhood does increase the risk of lung cancer and some of those related health issues. So Alex and Dr. Yang are probably much more knowledgeable on this. So if you guys want to add to any of that.
So right now, what they say the leading cause of lung cancer mortality in never smokers is radon. But other than exposure to radon, as Priyanka mentioned, there are many other risk factors that could increase your risk for lung cancer. Unfortunately, they're not understood well enough for us to act on them and be able to offer screening to certain individuals. But it is possible that an individual who has never smoked but has additional risk factors could be at a similar or higher risk for lung cancer as someone who does smoke. So yeah, there are many additional risk factors for lung cancer, and I do think pollution is one of them that does come up.
All right, anything else to add from our other panelists?
No, I think Alex and Priyanka, you said it well. I turned off my webcam because I was getting a signal saying that maybe that will help with the internet stability. So, but yeah, no, I completely agree with what Alex and Priyanka said. So.
Okay, very good. How do we prevent lung cancer other than being a non-smoker? Does regular aerobic or breathing exercises help?
You know, that's a good question. And then also, I was reminded of the previous question too, is when it comes to, you can kind of think of, I think, air pollution, anything that you might think is bad for your lungs in terms of causing inflammation. So breathing smoke, people have talked about, you know, if you do a lot of, for example, in Taiwan, there was a study just completed recently where they looked at never smokers, and one of the risk factors they had been looking at was also how much cooking people did and how much stir fry and oil and things like that. So in general, we just don't know quite enough how much this really plays in lung cancer, but we suspect it probably does increase your risk. And so that's something that in the next 5-10 years, hopefully we'll be able to get better answers. In terms of decreasing your risk of lung cancer, probably the best thing to do is to try to minimize your exposure to air pollution and to do all the things that people talk about that are healthy. So eat a healthy diet, fruits and vegetables, reduce refined carbohydrates, try to keep a healthy weight and an active lifestyle with exercise. And basically anything you think of that will be helpful, not just to reduce your risk of lung cancer, but also to reduce your risk of obesity, diabetes, and other types of cancers will be helpful for lung cancer. There's not any specific, at this point, there's not anything more specific that I know of that can help you reduce your risk. So.
Okay, if someone had a previous pulmonary embolism, would it put them at a higher risk for lung cancer?
Not that I know of right now.
Okay. If a human having cancer in the body, let me try and reframe this. If someone has cancer elsewhere in the body, how do you prevent it getting to the lungs?
That's a great question. Sorry, can you say that? Can you ask that question one more time? Sorry.
Absolutely. If someone has cancer elsewhere in the body, how do you prevent it from getting to the lungs?
Oh, that's a really good question as well. It's, at least right now, we don't know how, but that is something that I actually don't know how many people are actively researching that, but it certainly deserves our attention. So.
See if we have anything else. Yeah, I think we answered the pulmonary embolism question. Did we do the pulmonary embolism? We did not. Okay. The only other question I think we have, which is not totally what we covered, but it's an interesting question to answer. So what is a biopsy?
That's a great question. So a biopsy, in the most general sense of the term, is just looking at tissue that's removed from the body to see if there's some kind of disease. So it doesn't have to be for cancer. It can be for many things. Now, in the setting of lung cancer, a biopsy usually means a radiologist, a trained doctor who does biopsies will put in a needle and put it right where they think the cancer is and extract and get some of that tissue out. But another way to do a biopsy is through surgery, which is what I do, and usually I try to do this minimally invasively with just a camera and some long, thin instruments. It's called VATS surgery. And then you remove a small wedge of tissue, and you can then look under the microscope and see in that manner what if there is lung cancer or what kind of lung cancer there is. So people nowadays, Alex, do you want to talk about liquid biopsies a little bit and things like that? Or, but people nowadays are trying to see if you can bypass actually removing real tissue and just look at the blood and look for pieces of DNA from tumor cells that are in the blood, and that's called a liquid biopsy.
So looks like there are no more questions there. But before we conclude, I would like all of you to summarize a little bit about the final thoughts. Can we start with Dr. Yang?
Sure. So, well, thank you again. We really appreciate everybody's time here. This is a really important topic on lung cancer screening. And please, I would say a couple of final thoughts are, please share this information with your family and friends. And also if they have any questions, they could always go onto our website and then send us an email. We'd be more than happy to respond. And then if anybody would like to join us to help us spread awareness, Priyanka, Alex, and I, we'd love to work with you in any way, shape, or form, either through collaborations or, as one of our team members. So thank you again.
Thank you. Alex?
Yeah, I just want to reiterate everything that Dr. Yang said and really express our appreciation for, you all for helping us set it up and giving us such a wonderful platform to spread awareness on, as well as for all the attendees who came to listen and learn. And then just to emphasize that this is such an important problem, but by working together and raising awareness, giving these presentations and talking to our friends and family members, we can make a huge difference and really save lives. So I just strongly encourage everyone to bring it up in discussion and make sure that your family members know about it and your friends know about it. So, and then if you have any questions, feel free to reach out to Alcy, and we're more than happy to answer any questions or have you join us and help us with this initiative.
Okay. Yeah, before we go to Priyanka, there are a couple of questions popped up. You want to get to it, Dr. Paulo?
Yeah, so one, I think we'll defer. Hold on, let me get back to these questions. I just minimized that screen. Here we go. Is there any research going on developing drugs that directly target the cancerous cell?
Yes, there's a lot of drugs right now that are being developed that I think what the question is alluding to is maybe targeted therapy. So these are drugs that attack certain parts of a cell if a patient has a certain mutation. And the other kind of therapy that is different from the traditional therapy is immunotherapy. And these are drugs that help your immune system fight cancer. And they also target very specific receptors and markers on the surface of the tumor cell. So, and that's really exciting, actually. So a lot of these are either in clinical trials or have just been published and are continuing to change our field. So.
Okay. And if someone has seasonal allergies, does that increase their risk for lung cancer?
Hey, Alex, do you want to take that one?
I'm not sure. I just know, so asthma, anything that causes inflammation in your lungs will, in theory would increase your risk for lung cancer. So if you have allergies that do increase the inflammation in your lungs, that could potentially increase your risk for lung cancer.
Yeah, although I would say that seasonal allergies, most likely it will not have any, if you have seasonal allergies, do not worry. And if you have seasonal allergies and you don't smoke, I wouldn't worry at all about your lung cancer risk. So, but as Alex says, that's still an area of active investigation right now. But just having your traditional seasonal allergies, your risk is going to be really, really, really low. So.
Yeah, I want to go back to something that you said, Dr. Yang, earlier, right? In terms of, healthy lifestyle. We tend to have in this foundation, right, folks who are very hardworking, who make sure that they support the community, make sure that their kids go to school and learn, right? But don't necessarily spend the same energy on their own health. And so all of the things associated with their own health, cancer screening being one of them, but being active and exercising being another, are really important. And I think over time, what we're going to find, right, is that there is a vascular component. In other words, how much blood flow goes to various parts of the body impacts whether cancerous cells come or not.
Yeah.
And so naturally we're going to find, and this might take 10, 20, 30 years, but we're going to find that areas that get better blood flow, right, are going to be healthier. Tissue will be healthier with good blood flow. And overall, eating well, drinking enough water, not drinking the wrong substances, getting aerobic exercise, right, all of that is going to wind up helping. And so, you know, we don't have these clear cause and effect answers in medicine today, but it's definitely worth investing the time in yourself to be able to eat better, drink better, breathe better.
Absolutely, that's so well said.
Thank you. There's one last question. It says, what is the risk of lung collapse during the lung nodule biopsy? Is there anything?
That's a really good question as well. It happens sometimes, and I've seen it happen. Usually, if it depends on the situation as well. I would say if you have a good radiologist and they're careful, and there's not what we call emphysema. So if there's not areas where the lung is filmy like tissue paper and things like that, your chances of getting lung collapse, or what they call pneumothorax, is going to be low, like very, very low. So and that, I would say, I wouldn't let that discourage you from getting a biopsy if you're worried about that. If your lung does collapse, then the treatment for that is usually they'll figure it out immediately, and then they'll just put a small tube, what they call a pigtail catheter, into the chest and make sure your lung re-expands, and patients can go home as soon as the next day. So I think that those are some considerations when doing the when figuring out whether or not you want to do a needle biopsy or not.
Thank you. And let's proceed with the final thoughts with Priya.
Yeah, sure. So I just want to echo everything Dr. Yang and Alex already said earlier. Thank you to all the attendees for taking time on a Sunday to attend our presentation. And we hope that you're able to leave the presentation with a little bit more information on lung cancer and lung cancer screening. And like we said before, if you are interested in learning more, we do have 5 handouts attached here, and also more resources on our website. And if you would like to attend any of our events that are posted on our ALSI website, we have various guest speakers who come to talk about lung cancer. So we'd love to have you join there. And additionally, I want to conclude by just emphasizing that one of the best ways to increase the lung cancer screening rate is simply by raising awareness in our communities. And it can begin with just starting a conversation with our friends, families, and loved ones. Yeah, and thank you again once to NSF for giving us this wonderful platform to share what we have.
Thank you. And Dr. Balu?
All right, thanks very much to all of our speakers. Appreciate you taking the time. Appreciate you proactively making sure that our community gets this information. To all of our community members, thank you for joining. Thank you for continuing to follow our events. Thanks very much, everyone. I hope you have a great rest of the weekend.
Great, thank you.
All. Thank you all for attending, and thank you, Dr. Yang and Alexandra Porter and Priyanka, for your time, patience, and then explaining things to us. We learned a lot today. Good luck to you all, and then please stay healthy. Please take care of yourself, and then we'll see you right back here the next time.